Understanding major placenta previa. To fully understand major placenta previa, you must understand what the placenta is and the role it plays in pregnancy. The placenta, which you may have heard be referred to as the afterbirth, develops alongside your baby in the uterus throughout your pregnancy. The placenta attaches to the wall of your uterus and provides a connection between you and your baby through your baby's umbilical cord. While your blood and your baby's blood does not actually mix in the placenta, it is the point where oxygen, nutrients, and waste products are exchanged, and therefore it is essential in the growth of your baby. Maternal blood flow to the placenta increases throughout pregnancy, so towards your baby's due date, 600 to 700 mils, which is equivalent to a bottle of Coke, is pumped through to the placenta per minute. The placenta stays attached to your uterine wall until your baby is born. So, what is major placenta previa? Major placenta previa is when the placenta attaches low down in the uterus and completely covers the internal part of your cervix, which you may hear medical professionals refer to as the internal os. In the very beginning of your pregnancy, the fertilized egg can implant into any area of your uterine wall, and the placenta will grow from there. Quite often, the fertilized egg may implant low down in the uterus, and women will be told at their anatomy scan that they have a low-lying placenta. However, in most cases, as the uterus grows, the placenta migrates with the uterine wall, upwards and away from the cervix. Unfortunately, for some women, the placenta continues to lay in the lower part of the uterus, covering the baby's exit. You may be wondering why placenta previa has happened to you. As explained earlier, the egg can implant anywhere in the uterus. However, there are a few factors which have been correlated with an increased risk of developing placenta previa in your pregnancy. These risk factors include advanced maternal age, smoking, cocaine use, having had one or more previous cesarean sections, having had multiple pregnancies, assisted reproductive technology, and prior placenta previa. While you might not tick any of these boxes, unfortunately, placenta previa is always a possibility during pregnancy and occurs in about 4 of every 1,000 pregnancies. Because the placenta is rich in blood vessels, if it is implanted over the outlet and in the lower part of the uterus, bleeding can occur when the bottom part of the uterus thins and spreads to accommodate the growing baby, and if the cervix starts to dilate. If the placenta detaches due to thinning or dilating, bleeding will occur from the placenta vessels. As explained earlier, the placenta receives up to 700 ml of maternal blood per minute. So the biggest concern is the mother losing a large amount of blood and subsequently reducing oxygen to the baby. If your placenta is low-lying at your 20-week scan, you will be offered a follow-up scan at 32 weeks of pregnancy to see if your placenta is still low-lying, and it will closely look at the length of your cervix to predict whether you may go into labour earlier and have a higher risk of bleeding. This scan may include a transvaginal ultrasound to get the most accurate measurements. Unfortunately, if you are considered to have major placenta previa at 32 weeks gestation, it is unlikely that your placenta will migrate away from your cervix. Unfortunately, I cannot tell you exactly what the rest of your pregnancy will look like. Some women may not experience any bleeding at all during their pregnancy and be considered safe to stay at home until their booked caesarean date, whereas some women may experience bleeding more regularly and require close monitoring in hospital. The care you receive is based on many factors, such as your pregnancy, overall health and medical history, extent of the condition, your tolerance for specific medications, procedures, and therapies, and your opinion or preference. Your care provider will tailor your antenatal care based on your individual needs and social circumstances. For example, the distance between your home and hospital, availability of transportation and support people, ability to rest at home, previous episodes of bleeding, your blood results, and your acceptance of receiving blood products. If you have younger children at home, it is sometimes difficult to rest, so your care provider will take this into account when planning the remainder of your care. Women with confirmed placenta previa at 32 weeks gestation but without any symptoms of bleeding are generally managed at home, but safety precautions should be put into place, such as having an adult available to help as necessary and ready access to the hospital. If your diagnosis is major placenta previa, your care provider will likely recommend rest and reduced activity, which means avoiding a few things that can trigger bleeding, such as exercise and sex. The delivery timing will be tailored according to your symptoms of major placenta previa and the well-being of your baby. For an uncomplicated placenta previa, the aim of delivery time will be between 36 and 37 weeks gestation. For women with major placenta previa and a history of vaginal bleeding or other risk factors for preterm delivery, a late preterm delivery between 34 to 36 weeks gestation will be considered. Your care provider will likely recommend steroid therapy between 34 to 36 weeks gestation, which is ideally given within 7 days of delivery, to assist in maturing your baby's lungs and reduce the need for respiratory support after birth. If you have been told that you have major placenta previa, you will require a C-section to ensure the best outcomes for you and your baby. Some women may find this very disappointing, especially if they are having their first baby or previous babies have been born vaginally. However, gentle caesareans are becoming much more popular and can assist in creating a special place for women and their partners that imitate a vaginal birth. The aim is to allow women to be as involved in their birth as possible. Speak to your care provider about your wishes. This might include having music playing in theatre, being able to see your baby born through a clear drape, and starting skin to skin as soon as possible. This will likely only be possible if your baby is close to 37 weeks gestation and is not requiring any respiratory support at birth. The aim of your delivery will be to have a healthy mum and a healthy baby through an elective caesarean, meaning it will be conducted on an agreed date. The purpose of this is to conduct the procedure during daylight hours when a team of experienced staff members are present. If your medical team is concerned due to ongoing bleeding or your baby is compromised, you will likely go for a non-elective caesarean, meaning the procedure will be conducted earlier than the agreed date or time. Because major placenta previa places you at a higher risk of bleeding at delivery due to the nature of the lower segment of the uterus, which struggles harder to contract, the anaesthetist will be in charge of giving you medications to help prevent the bleeding. If you have signed a consent form for a blood transfusion, the hospital will most likely have matched blood products readily available to be used if required. Unfortunately, routinely, prior to caesarean sections, women will be asked to sign a consent form to a hysterectomy as a life-saving procedure if bleeding cannot be controlled. This may be scary for women, however, studies have found that only a small number of women with placenta previa have required hysterectomies at delivery, and largely depended on whether they gave birth in a developed country or not. It also depended on how deeply the placenta was embedded in the uterus. Fortunately, a caesarean for previous major placenta previa does not exclude you from attempting a vaginal birth after caesarean, also known as a VBAC. It is always important to consult with medical professionals about attempting a VBAC, and remember it is ideal to wait at least 2 years to let your uterine scar heal before becoming pregnant again and attempting a VBAC. In a developed country with adequate health services, babies have an incredibly high survival rate when born under the circumstances of placenta previa. Although your baby may be born a little early and is still considered premature prior to 37 weeks gestation, the amount of assistance he requires will likely depend on the gestation he is born at and the maturity of your baby's lungs. A baby doctor called a paediatrician will be at the birth to assist your baby as required, and you will be cuddling them in no time. Just remember that you are amazing no matter how you birth your baby. But if you are feeling anxious or overwhelmed with the diagnosis, please voice this to your care provider. They can discuss your situation at an individual level. As explained in this video, every case is so different. They can also refer you to appropriate healthcare providers to help you work through feelings of anxiety and the unknown.